Welcome once again to another session of the liver transplantation series on the LGS forum. Tonight we'll discuss transplanting not just one organ but two. We will look at simplifying the complexities of a combined liver and kidney transplantation. Now the relation between the liver and the kidney is a very intricate and codependent one. Renal failure in cirrhotics is associated with a poorer prognosis and a drastically decreased overall survival. This negative effect is also evident in the post-transplant setting, as shown by reduced graft and patient survival. Now, we also know hepatorenal syndrome is an integral complication of chronic liver disease, and close to half of all chronic liver disease patients have some form of renal dysfunction. However, it is important to define the possible reversible causes of kidney dysfunction and set precise boundaries between functional and irreversible damage. The decision to perform combined liver kidney transplant rather than a liver transplant alone is important because the benefits to the patient with liver disease of receiving a kidney on one side must be balanced with the downside of that kidney not being offered to a patient with end-stage renal disease. So, do all of them need a combined liver kidney transplant, or are some renal dysfunctions reversible? If so, which ones and how do we predict them? To educate us on these aspects of combined liver kidney transplant is our first speaker, Dr. Swaminathan. Swami, as he is popularly known, heads the transplantation services of GEM hospitals across the country. Having done his basic surgical training in India, Dr. Swaminathan completed his ASTS fellowship from Iowa in the United States. Apart from having performed over 500 kidney transplants, 500 liver transplants, laparoscopic, robotic, renal, and liver donors, he has numerous other firsts to his name. He performed the first successful pancreas transplant in North India. But what stands out for me on a more personal basis is his long association with the liver transplant program at Stanley Medical College. He started the liver transplantation services, he helped start it there in Jan 2009 and spurred on numerous GI surgical residents, including myself, towards transplantation since then. Now, with two organs being transplanted, there are various permutations and combinations involved, leading to dilemmas across indications, regions, and age groups. The frequently debated ones are those of simultaneous versus sequential transplant, especially in a deceased donor versus a live donor setting, and in the adult versus the pediatric age groups. These are decisions which are crucial from a surgical, medical, ethical, and even a cultural point of view. To speak to us about all this will be our second speaker, Dr. Gomati Narasimhan. Dr. Gomati is a multi-organ transplant surgeon and has been an integral member of Professor Ella's team for over a decade now. She did her basic surgical training in India, followed by an ASTS transplant fellowship at Baylor in the United States and short fellowships in the Far East as well. Also having done management courses from the IIM, Dr. Gomati now holds the reins on the doctors and healthcare workers at Rela Institute. An excellent clinician, an amazingly patient teacher, a seasoned marathoner, a fitness enthusiast, I could go on and on. There is unlikely any role which he doesn't excel at. It's no wonder that Dr. Gomati is held in such high esteem and remains a role model for all of us in the team to emulate. But before we hear her talk, let's hear it from Dr. Swami. I'm not sure if he's logged in.
He's logged in, yes.
Yeah.
Welcome, Samal.
So, good evening, everyone. Thank you, Dr. Patta Radhakrishnan, sir, and thank you, Ashwin, and dear friends and colleagues. It's a wonderful opportunity to share the thoughts about combined liver kidney transplantation. I can see a lot of people from the transplant specialty. I hope it's going to be an interesting discussion, being a very gray area. Let me share my screen. All right, thank you very much. Let me start with the presentation. So this being a very controversial area, I'm just going to talk mainly about the indications and the operative options for a combined liver kidney transplant, and subsequently Dr. Gomati is going to talk more about the controversial areas and the decision making when to do a kidney and when to do a combined liver kidney. Just to give an overview, renal dysfunction is not uncommon among the cirrhotics, and somewhere about 20 to 48% of the decompensated chronic liver disease patients have some degree of renal dysfunction. And we all know that renal dysfunction is an important worse prognostic factor predictor in the pre and post liver transplant areas. There are a spectrum of causes which could cause renal dysfunction in patients with cirrhosis. It could be a simple pre-renal AKI due to hypovolemia from GI bleed or an excessive use of diuretics, sepsis due to SBP or other causes. It could be due to hepatorenal syndrome, which is again unique to cirrhotic patients. The kidney injury is due to an imbalance in the vasoconstrictor and vasodilator, causing some intense intrarenal vasoconstriction. Again, there are a couple of types, type 1 and 2. I'm not going to go into the depths of it, but type 1 is mostly reversible, and type 2 can cause irreversible renal injury, where we need to consider a combined liver kidney transplantation. And there is another subset of patients who have intrinsic chronic renal disease, particularly, for example, patients, cirrhotics due to NAFL may have some underlying diabetic nephropathy. These people use a lot of drugs, and they may end up getting some interstitial nephritis. Hep C can have some GN glomerulonephritis. And there could be an associated chronic kidney disease, which may worsen during the decompensated phase, and which again will worsen after transplant. So why are we talking about combined liver kidney transplant? Can't we not just do a liver transplantation, which is life-saving, and then wait for a kidney transplant, and whenever we get a kidney, we can do a kidney transplantation? The reason is because renal dysfunction, as we all know, is the greatest determinant of mortality in the end-stage liver disease patient. In fact, creatinine has been given so much of weightage in the MELD score. Liver transplant candidates with the renal dysfunction, whether they are on dialysis or even if it's a mild to moderate renal dysfunction, have a very high waiting list mortality. And the post-transplant survival very much depends on the degree of pre-transplant renal dysfunction and the duration of dialysis these patients undergo prior to transplantation. The chart on the right shows the waiting list mortality of liver transplant alone versus patients who had a renal dysfunction and then waited for liver transplant or for SLK. Similarly, the graph below shows the outcome or the survival post liver transplant alone for patients with renal dysfunction versus those who received SLK. So we can see the lowest line is the liver transplant alone for patients who had renal dysfunction or who were on dialysis but only got a liver transplant. So it is actually the transplant team's role to identify that subset of patients who will be benefited by kidney transplantation. In fact, combined liver kidney transplantation is not that common. Approximately 6 to 8% of all liver transplants are combined liver kidney transplant in most of the international registries. It's indicated in, we can consider combined liver kidney transplant in 3 subset of patients. One is the chronic liver disease patient or decompensated chronic liver disease patients who has well-established end-stage renal disease on dialysis, as I mentioned before, like patients with diabetic nephropathy or other kidney diseases who are already on dialysis. Metabolic disorders like primary hyperoxaluria type 1 or 2, polycystic kidney liver disease, alpha-1 antitrypsin deficiency with associated glomerulonephritis, FAP, and atypical HUS. I'll talk about these metabolic disorders in a little bit detail subsequent slides. And the third subset are the most important ones where we still have a controversy, the HRS, AKI, or maybe the stage 3 to 5 CKDs who are not yet on dialysis and they have a decompensated chronic liver disease. This is a group we need to ascertain whether the renal dysfunction is going to remain stable or is going to worsen or get better after liver transplantation. So we need to identify the right subset of patients and give them the kidney transplantation. So what are the options for a liver kidney transplant? Can do a simultaneous combined liver kidney transplantation from the same deceased donor, or a simultaneous liver kidney transplant from live donors. Obviously, there'll be two different donors if it's going to be an adult recipient, or it could be from a same donor if it's a small kid, pediatric. You can consider a left lateral donor and a lap nephrectomy from the same donor. A delayed kidney transplant after the initial liver transplantation from the same deceased donor, which is a very new concept which has been attempted by a few centers in North America and Europe. And then the sequential kidney after liver transplantation from deceased or live donors. Obviously, that will be from two different donors. So coming to the first subset, which is patients with well-established renal failure on dialysis, as well as a decompensated chronic liver disease. They undoubtedly need a liver and a kidney at the time of presentation. But there is also another group of patients, the dialysis patients, who has some asymptomatic or stable cirrhosis. Somewhere about 10 to 20% of the patients on hemodialysis are either HCV positive or HBV positive, and a significant proportion of them will have a child-size cirrhosis or in fact, a very stable, well-compensated cirrhotics. These patients, do they need a liver transplant as well, in addition to a kidney transplant? Actually, there is no data regarding a need for transplant in these patients, particularly if they're child-size cirrhotic. And this is a simple algorithm that can be used, basically end-stage kidney disease with a stable cirrhotic. If there is no evidence of portal hypertension, or if there is no decompensation, if there is evidence of decompensation or if there is evidence of portal hypertension, then consider a combined liver kidney. If they are asymptomatic and it's a child-size cirrhotic, we can consider a liver biopsy. If it shows cirrhosis, and if the wedge pressure does not show any evidence of portal hypertension, then a kidney transplant alone. Or if the wedge pressure shows portal hypertension, then a combined liver kidney. If the liver biopsy does not show any cirrhosis, then a kidney transplant alone will suffice. So coming to the metabolic disorders, primary hyperoxaluria type 1 and 2. Probably PH type 1 is probably the most common indication for kids for a combined liver kidney. It's due to mutation in the AGXT gene, the alanine glyoxylate transferase deficiency. So this leads to deficiency of the enzyme, and that leads to a conversion of glyoxylate to oxalate instead of glycine. So the oxalate gets crystallized with calcium and deposits in the kidney, leading to nephrocalcinosis and subsequently renal failure. So the options are, obviously, isolated renal transplant is not an option. In fact, we've seen a few cases where the patients had undergone previously a kidney transplant without a diagnosis of PH1 being made, because we don't widely use in India the genetic testing. So by the time they present to a nephrologist, they have burnt out kidneys, so you won't be able to identify the urinary oxalate to ascertain a diagnosis. So they end up getting a kidney transplant, and then the oxalate gets deposited in that graft very rapidly, and they lose the graft. And so now it's well accepted that an isolated kidney transplant should not be done for a PH1. And in fact, there are reports of preemptive isolated liver transplant or even an auxiliary partial liver transplant with a left lateral robe, particularly when the kidney functions are well preserved with a GFR of over 60, which can pretty much preserve the kidney and prevent any further damage to the kidneys. If the GFR is somewhere between 30 and 60, then we can give a liver transplant first to see if we can buy some time with the kidney function that is already there. And when they go in for a frank, when the GFR goes down below 30, or if they go on dialysis, then a kidney can be given sequentially. But however, a combined liver kidney is probably the treatment of choice for small children and infants, particularly to avoid the systemic effects of oxalosis, and also in young adults or adolescents whose GFR is below 30. Type 2 PH is a bit more a late presenting disease, and it's not, the defect is not only in the liver. So there is still some controversy whether type 2 PH will benefit by a combined liver kidney, because there still will be some oxalate production from the peripheries. Autosomal recessive polycystic kidney disease. The mutation is in a gene encoding for fibrocystin. Deficiency of this leads to formation of multiple medullary and corticomedullary cysts in the kidneys, and portal fibrosis, dilatation of the biliary tract, and malformation of the ductal plates. The extent of involvement of kidneys and livers are variable. So almost 70 to 90% of these patients can be treated with either isolated liver or kidney transplant, depending on the extent of if needed. If both organs are functionally involved, then a combined liver kidney is needed. Other metabolic disorders, they're very rare, and methylmalonic acidemia, alpha-1 antitrypsin deficiency with concomitant membranous glomerulonephritis. In fact, isolated liver transplant sometimes reverses the MPGN. So many centers now recommend, or in fact the literature recommends first liver transplant, and if the MPGN doesn't reverse, then a sequential kidney. Atypical HUS used to be an indication for a combined liver kidney, but with the advent of eculizumab, which is an anti-CD5, C5 monoclonal complement 5 monoclonal antibody, that has become the first-line treatment with isolated kidney transplant, and only in cases which are eculizumab resistant or a recurrent disease will require a CLKT. However, eculizumab is not available in India out of trial basis. So I think still in India, the option would be only a combined liver kidney transplant. This is a subset we are talking about, the chronic kidney disease stage 3 to 5, or AKI or HRS. We don't know exactly who's going to recover and who's going to deteriorate or require who's going to be benefited by a kidney transplant. The important argument here is giving a combined liver kidney transplant to these subset of patients is going to divert a substantial number of kidneys, deceased donor kidneys particularly, away from the candidates who's been waiting for kidney transplant for a very long time. So the decision has to be very careful. There are several guidelines presently used by various transplant societies. They look into certain factors like the severity of acute kidney injury, which is determined by the eGFR, and the duration of AKI prior to transplantation, and the duration the patient is on dialysis. These are the key factors they take to decide whether the patient will need a kidney transplant or will be benefited by combining a kidney with a liver transplant. So these are the criteria for listing and transplantation used by most of the transplant societies. Metabolic disease obviously is a different category, and patients with end-stage liver disease and end-stage kidney disease. For those who are not on dialysis, that is chronic kidney disease with a GFR of less than 30 ml per minute and a proteinuria of more than 3 grams and a urine protein creatinine of more than 3, who are not on dialysis, can be considered for waitlisting and transplanting. And a sustained AKI requiring dialysis for more than 6 weeks, or a sustained AKI with a GFR of less than 25 ml per minute for more than 6 weeks, not requiring dialysis, or a combination of the above two factors. So these are the categories of patients who will benefit by listing for a kidney transplant as well as getting a kidney transplant. Of course, there are arguments from the nephrologist that a lot of kidney patients are waiting, and this is diverting a substantial number of kidneys to the combined organ, not only to a liver kidney, but also this means they're diverting it to the heart and kidney and other combined organ transplants. And in fact, there is a small bias here, because to go on a kidney transplant waiting list in India or any other country, you need to have a GFR of less than 20, or you need to be on dialysis. Whereas to go on a combined liver kidney, you need a GFR of only 30. If it goes below 30, you can stay on the liver list and pull a kidney. So that's a liver pulling a kidney, which the nephrologists don't like. The argument from a liver point of view is because you can't expect a lower GFR in cirrhotics, a creatinine clearance in cirrhotics, because the creatinine production itself will be low. And again, you would expect some degree of decline in GFR if you give a liver transplant alone and put them on CNI. So that's the reason why the GFR is kept at a higher cutoff than 20 for a liver kidney listing. And the nephrologists, the second argument is we are diverting a substantial number of very good quality kidneys, the low KDPI kidneys. Basically, they are basically means that very good quality kidneys, which otherwise would have gone to serve some children or the pediatric group or some young adults. And from an utilitarian point of view, we could have derived more number of life years from transplant had we transplanted the same kidney in a younger patient rather than transplanting into a sicker and older combined liver kidney patients. In fact, they also there are a single center study which shows that patients who received a combined liver kidney transplant, when they did a post-CLK radionuclide renal scans, they showed that almost a third of those patients recovered their native GFR to almost 20 ml per minute. So in a substantial number of patients, are we giving unnecessarily kidney transplants? So there are several arguments in favor of simultaneous liver kidney transplants. Obviously, there are several single center studies and registry-based studies which have demonstrated the superiority of combined liver kidney transplant over liver transplant alone in patients with dialysis or renal dysfunction. Dr. Gomati will go into details of those things. And also there is a distinct immunological advantage of combining liver and kidney from the same donors, because liver protects the kidney, and it's called as a combined organ effect. It's not only seen with the kidneys, it's seen with all combined organs, liver, kidney, liver, heart, or simultaneous KP, liver, intestine. So there is a protective role played by liver. And so that is one of the reasons also to consider a combined liver kidney from the same donor. Again, the arguments in favor of liver transplant alone or a kidney after liver transplant is, as shown by a few studies, that more than a third of these patients had a substantial improvement in their renal function in long term, with the GFR improving above 60 ml per minute. In fact, the frequency of end-stage renal disease after liver transplant alone is only 6 to 10%, but a substantial number of patients receive a combined liver kidney. In fact, a recent UNOS database analysis showed a slightly inferior 10-year kidney allograft survival in a combined liver kidney recipients when compared to kidney alone. I think personally, my take on this paper is basically, more than 50% of the kidneys allotted for a combined liver kidney are marginal kidneys. So they all end up getting high rates of DGF and a poorer 1-year survival. But then again, there was one more study, that's a mate kidney study. Basically, one kidney goes into a CLK and the pair kidney goes into a kidney alone recipient, and looking into paired kidney analysis showed a slightly inferior kidney survival in combined liver kidney group. Again, there is a reason for that, which is again my personal theory, that we don't do a cross match for a combined liver kidney transplant, and we won't know the status of, or we never characterize the status of preformed HLA antibodies. And although the liver is protective to kidney, in a long run, the class 2 DSA, high PRA are detrimental for both liver and kidney grafts. More and more data are emerging about on that area. This is called as a safety net approach, which has recently been included in the US allocation policy, where a patient with a chronic DCLD who had a renal dysfunction or who underwent a liver transplant under this policy and approach the patient, if they develop a renal failure or either hemodialysis or if their GFR drops below 20, between the first 2 months to 1 year after liver transplant, they are granted priority for kidney listing and they pull a kidney very quickly. So this approach pretty much avoids the non-beneficial use of deceased donor kidneys in those who either would have recovered or would have died regardless of whether they received a kidney or not. And this also gives an opportunity for us to do the liver transplant, do a thorough immunological workup, and then give a good matched kidneys. We can characterize the preformed antibodies that usually drops after a liver transplant. And if there are still some pre-existing antibodies, pre-treatment can be given and a kidney transplant can be done in a much more controlled environment. And it significantly lowers the DGF rate, obviously, because we are avoiding the hemodynamic instability that happens during the liver transplant and the reperfusion injury and the post-operative injury that the kidney incurs during a combined liver kidney transplant. And this gives an option of using even a marginal kidney and still avoid a DGF, which otherwise would have been inevitable with a combined liver kidney setting. This is another approach recently popularized by few centers. In fact, we ended up doing one by chance rather than a choice. We planned for a combined liver kidney for a patient, but then waited for too long on the waiting list. Then we prepared a living donor kidney. But on the day of transplant, we got a young liver, shared kidney, a shared liver. We didn't have the time to do the kidney. So we ended up doing the liver because it's a good quality liver. We want to get the liver done. So we did the liver. And then 48 hours later, we did a living donor kidney transplant in the patient. But until then, we maintained the patient on CRRT. Patient was stable, off inotropes, completely stable. And then 48 hours, we did a kidney transplant, had an on-table urine, and kidney picked up within a few hours. So that was, of course, we went through the literature to see if what we were doing was right. And then we were surprised to find that there were quite a few publications on that about this delayed kidney transplant in a combined liver kidney transplantation. Of course, this is from same donors. I'm talking about from different donors, but this is the same donor. Basically, they do a kidney transplantation, liver transplantation first, and then they put the kidney, delay the kidney transplant by 48 to 72 hours. The rationale behind this approach was the kidney grafts are more susceptible for acute kidney injury or delayed graft function when transplanted at the same time with the liver, obviously because of the hemodynamic instability, hepatic reperfusion injury, and then in the post-operative setting, we would like to maintain a low CVP, and due to cirrhosis itself, there is a low perfusion pressure, peripheral vasodilatation requiring inotropes. So once all these things could result in a decrease of about 15 to 20% of GFR in the first 2 to 3 days after transplant. So by delaying the kidney transplant by 48 to 72 hours, by pumping the kidneys on a hypothermic machine perfusion and then transplanting after 48, 72 hours, once a patient is completely stable, coagulopathy settles off inotropes, you can pretty much avoid the DGF, which is associated with the same time in transplantation. So this is a paper from Indiana, looking at about 130 combined liver kidneys. 69 of them were simultaneous and 61 was delayed kidney after liver transplantation with almost a mean cold ischemia time of 51 hours. All these kidneys were pumped, and the recipient and donor characteristics were comparable within the two groups. There was interestingly, there was no DGF was observed in group D, even after using marginal kidneys and a cold ischemia time of more than 50 hours when compared to the previous era where they pretty much there was a 20 to 30% DGF rates. That probably reflected as a poor survival of kidney grafts at 1 year and 3 years. The serum creatinine levels among the surviving patients at 1 year, 2 years, and 3 years were all similar. And obviously, the reason for low DGF or nil DGF is because all the kidneys were pumped, and that actually helped to clear the products of anaerobic metabolism, and it reduces the intrarenal vasoconstriction. So the operative techniques, whether it is a combined liver kidney or a sequential liver kidney, it's always a liver first with a standard technique, either a piggyback or side-to-side ostomy. We've always used intraoperative CRRT and continued postoperatively until we get a reasonable renal function. Kidney implantation could be either in the right or the left extraperitoneal space through the modified Gibson approach. That's for a cadaver liver, we mostly use this Mercedes, but for a live donor, we use Makuchi. Implantation could be a classical technique or a piggyback or side-to-side ostomy. I haven't done a classical technique in a long time in cadaver transplants, but just for people who are curious, it's where the liver is completely taken off with the cava. And I don't have a picture of a standard classical technique, so I'm just showing one of the live donors where we had to take off the entire cava because of Bacchiari, and then we implanted the right graft onto the Dacron interposition graft, and that's how a standard interposition cava is done: upper caval anastomosis and then the lower caval anastomosis, and that's a completed anastomosis. In a cadaver setting, we'll just clamp the cava above and below, take the knock of the liver, and then do an upper and a lower caval anastomosis. Piggyback is probably the most common technique most of the centers use. This is a slight modification where there is a extension where the cava is fully preserved and all the right, left, and middle veins are combined into a common cloaca, and if needed, extended down to form a triangular cava-ostomy. I use only a side-to-side cava-ostomy for most of my cadaver transplants, where the back of the donor cava is cleared and a longitudinal slit of about 5 to 6 centimeters made, and then top end of the cava and the bottom end of the cava are stapled or closed with sutures, and then a side-to-side cava-ostomy is done like a standard anastomosis, first completing the posterior wall and then doing the anterior wall. It's just easy, and it's easy to train trainee as well with this technique. So to summarize, renal dysfunction in liver transplant candidate is an important worst prognostic predictor, both pre and post liver transplant. It's imperative that the transplant team identifies that subset of patients who will be benefited by receiving a kidney as well. It is still on about whether it is a simultaneous liver kidney or sequential liver kidney or a delayed kidney after a liver. There are plenty of data out there, and it is a choice and preference of the unit. The most important thing is an unjustified kidney transplant should be avoided because it's a valuable resource. I'm sure Dr. Gomati will talk more about the debate of the controversy about this simultaneous and sequential transplant. Thank you very much.
Thank you, Dr. Swami. It was a very comprehensive talk on the gray areas of combined liver kidney transplant. If we can have Dr. Gomati give her talk, and then we can have a few questions after that. And we have Prof in the audience as well. I'm sure we can get his comments. Dr. Gomati.
Swami, I think if you stop sharing, I'll start sharing.
Yeah.
Thanks, Swami. It was quite comprehensive. I think I'm going to have a little bit of duplication of your presentation here and there, but we'll try and see how we can get the perspective from, I would say, the Indian perspective of it as we go through. So I'm just going to clarify a few because these have been used differently in different places. In my presentation, it would be CLKT is combined, SLKT would be sequential. Liver after kidney, kidney after liver, liver kidney meaning we're just talking about both organs, and kidney transplant alone. The concepts based on which these decisions are being made is essentially that both organs have compromised function. It could be either from something which is genetic, congenital, acquired, like an AKI or HRS or CNI toxicity. Could be irreversible. It is irreversible rather when we make these decisions. That's the premise under which we do it. One organ may be more compromised than the other. CLKT provides immunologic and survival benefit. Prediction of irreversibility is fairly accurate with the current criteria, and that's why we offer them combined liver and kidney, and that there is adequate supply of organs. We're going to revisit each of these actually. When we say both organs are compromised and in a genetic situation, the genotype and phenotype, the correlation can be very variable. So just the fact that somebody has a genetic mutation does not warrant that they get a combined liver and kidney transplant. Similarly, in the acquired scenario, it's like Swami highlighted, this is the gray zone where, you know, the decision to overdo or underdo is always, there's a debate on it. And irreversible, or maybe there is a partial reversibility which we don't identify. And when we talk about one organ being more compromised than the other, it's usually in ARPKD. And in children, when we see this, combined liver kidney provides benefit, immunologic and survival. Does it always do that? We need to revisit that. Prediction of irreversibility is fairly accurate. Again, that's a big question mark. And when we say adequate supply of organs, adequate for whom? Is there equitable distribution of organs? And when we talk about live donor situation, is there donor risk justification? So I'm going to deal with one by one. Maybe in some instances it's the concept, in some instances it's the disease itself. When it comes to ARPKD, it's interesting that the presentation can be very varied. It can be the kidney disease, which is predominant, the GI, which is predominant. You could have a combination of symptoms here. And it's important to identify which type of symptom you would need to address first or address together. If a patient has advanced kidney disease with portal hypertension or advanced kidney disease with Caroli's disease, which usually presents with cholangitis, or is it going to be predominantly GI with absolutely stable kidney function? The reason is because 40% of patients with ARPKD have both severe renal and hepatobiliary. It's quite straightforward there to go for a combined liver and kidney. Whereas if the end-stage renal disease is predominant and there is no cholangitis, and there is no portal hypertension, then it's a kidney transplant alone. Whereas if portal hypertension is present along with the ESRD, then the patient is going to require maybe a shunt is an option that you can think about. But the main cause of mortality when you do a kidney transplant alone is from cholangitis and sepsis. And if the presentation is Caroli's in the liver, then whatever the liver function is and whatever the portal hypertension status is, it would be better to go for a combined liver and kidney transplant. We had a patient where the indication though was growth failure. This was a 9-year-old boy, growth failure, cholangitis, recurrent bleed, stable renal function. Interestingly, the explant comes up with an incidental fibrolamellar tumor. So there are always surprises. We go by what we know in the literature, but it's always good to keep our minds open for things that can always happen in any patient with a chronic liver disease or a chronic renal failure. Next comes primary hyperoxaluria, quite commonly seen in India, mainly because of patients in India, plus the referrals we get from countries around where the incidence, especially from the Middle East, is quite high for primary hyperoxaluria. Interestingly, even among the Indian patients, of late, there seems to be quite a lot of referral for combined liver kidney. It could be that these patients were predominantly handled by the nephrologist and treated with kidney transplant alone earlier, whereas now with the advent and success of liver transplant in India, more and more patients are being referred for primary hyperoxaluria. So the incidence is not really small in India, I would say. If you look at the overall combined liver kidney for children, the outcome for primary hyperoxaluria is much less compared to combined liver kidney for other indications for children. This just shows that this subset of patients are quite complex, need a lot of thinking through in terms of decision making for them. And even during the operative and post-operative phase, there are a lot of challenges in them, mainly because it's not just the liver and kidney. Primary hyperoxaluria is a systemic disease with multi-organ involvement. And the outcomes have definitely improved from earlier to 2002 to now. Though in centers abroad is the increased volume being concentrated into few centers. And as a result, the high volume centers have a much better outcome. Also, the debate about whether combined liver kidney transplant has a good outcome in very small children. And when it comes to kidney transplant, small children, the definition is less than 15 kilogram. Whereas in liver, we talk about 5 kilograms. So when a combined organ has to be given to children less than 15 kgs, the outcome was very poor, not anymore. Again, it's got to do with, I think, patients being referred to specific centers where the experience improves and the outcome also improves. This large group, the Oxal Europe group, probably has the largest experience with primary hyperoxaluria, like we all know. They've come up with very definite indications for what to do for different stages of chronic kidney disease associated with primary hyperoxaluria. The interesting aspect is to see, I think Swami touched upon this already, is when you think about a preemptive liver transplant alone. And usually this subset comes up only when family members are diagnosed to have end-stage kidney disease and the etiology is found to be primary hyperoxaluria. Rest of the family gets screened, the siblings, and then you probably pick up somebody who's early on in the disease, where the GFR is still not dropped to the point of needing a kidney transplant. Probably an option. Again, we say probably because the presentation is quite variable in different patients. Some of them go on to several years without having any problem in terms of presentation with kidney problem, although the oxalate levels will not show up in the early phases. The oxalate levels in the blood builds up only when the CKD worsens. Until then, the kidneys kind of handle the load. So that is one area where, the thought process has to be there in terms of preemptive. Again, when it comes to stage 5, there is an option. Again, the option is for trying with B6, but there is no real evidence for that. And then they go on to have, combined liver and kidney. Sequential because the load is quite high when they reach this point, the load of oxalate in the body. The worry is you do a combined liver kidney, and if the new kidney also gets deposited with the oxalate, you end up losing that organ. So again, thought process about sequential liver kidney is there when it comes to CKD stage 5. Big challenge that we face in India is having limited donor options. We're talking about live donors because getting a combined liver kidney organ for somebody, if they're foreigners or if they're Indians waiting on the list for a long time, it is a big challenge for children. Here we have a family, quite interesting the way we went about it. This older girl presented with renal failure, was diagnosed with primary hyperoxaluria, had a combined liver and kidney transplant from her uncle. The kidney failed in 1.5 years due to recurrent nephrocalcinosis, basically oxalate deposition in the new kidney. So she ended up on dialysis. Her mother donated kidney to her. That was her second kidney. In the meantime, her younger sister went on to develop end-stage renal disease. The family did know about it earlier, but there was no option in terms of having another donor to donate for her. The brother, who was at the time of diagnosis for this child about 18 years, in the next 2 years turned 20, and he was ready to donate for his little sister. So he donated the liver first. Subsequently, 3 months later, we went ahead and did the kidney. Why did we choose a sequential approach? Because we had a bad experience with this older girl where we did combined liver kidney and lost the kidney in about 1.5 years. So considerations about donor, how many do they have? And when it's a genetic disease, do they really have that many who can donate? Because some of them may be having high oxalate levels when you start screening them. All of this have a big impact on how you decide. So our series showed that, our experience basically is that sequential liver kidney transplant probably matches the greatest likelihood of successful outcome for recipient with the least risk to the donor. And this we're talking about live donor transplants, particularly in severe systemic oxalosis. We move on to the next aspect we discussed earlier, immunologic benefit. Do we really have an immunologic benefit by giving a liver and kidney? And to that, we can say an emphatic yes. There is no dilemma about it. There is nothing that we need to debate about. Interestingly, it's not just in the early phase. In patients who receive combined liver and kidney transplant, even in patients who have a high donor-specific antibody, the long-term outcome for combined liver and kidney is quite good compared to kidney transplant alone. So definitely both organs from the same donor has a huge immunologic benefit. What about survival benefit though? When we say survival benefit of simultaneous liver kidney transplant is not always true. We have to be very careful in understanding that the outcome clearly depends on the quality of the organ that's being given. When I say quality of the organ, it's both of the liver and of the kidney. If the liver is a good quality organ, if the liver and kidney are from a standard criteria donor, the outcome is good. Whereas if the liver, where we can accept a bit of an age-related changes in terms of the liver function, whereas if the kidney function goes in for a delayed graft function, or the kidney risk index is more than 1.1, the entire benefit that we spoke about in terms of survival for a combined liver and kidney is lost when it comes to the donor risk index being more than 1.1, which essentially means a very good quality kidney has to be offered to be able to give the survival benefit when it's a combined liver and kidney transplant. So there are ways people are thinking about novel concepts of expanding this, where a combined liver with dual kidney, essentially trying to offset the risk that is present with a marginal kidney by providing two kidneys, one liver and two kidneys, all marginal though. This group has presented their series with 4 liver dual kidney transplants with 100% survival. This is a very busy slide, but it's essentially trying to tell us that unless the graft, the liver graft, the renal graft is good, your benefit that you achieve with simultaneous liver kidney is lost, and especially if they go on to delayed graft function, which means needing a dialysis in the post-transplant period. So how can we take this forward? I mean, are there factors to tell us that delayed graft function can be avoided, or is there specific factors that we can look for and avoid? Essentially, the ones we spoke about. If the donor kidney, if the donor has hypertension, or if the preservation time is cold static preservation as opposed to machine perfusion, which in India is predominantly, we don't have machine perfusion yet. So we still do cold static perfusion. Preservation, sorry. And if the donor final creatinine value is every point increase in creatinine has a negative impact on the outcome, the MELD of the patient when they need a simultaneous liver kidney transplant, and the duration of delay in kidney after liver transplant. So these factors do have a great impact. A kidney delayed graft function, which means needing dialysis in the first 7 days post combined liver kidney transplant, has a significantly lower outcome compared to if you have an immediate graft function in a combined liver kidney transplant. Basically, the futility rate of the kidney graft is 30.5% in patients who had a delayed graft function. Also, very important is not just the renal graft, but the medical acuity of the patient who's undergoing transplant, which essentially means a sick patient, high MELD, not necessarily contributed by the renal component, but the liver component also have a poor outcome compared to patients who are reasonably stable. The next important factor is trying to understand reversibility, or shall we say the irreversibility. How much do we know about it? The outcomes and native renal recovery. This is something which is interesting, which the Josh Levitsky group from Chicago started looking at, and this was quoted by Swami too. So essentially what they did is they picked up all the patients who underwent simultaneous liver kidney transplant, and in about 78 of them, of the 155, they went ahead and did renal scans, DTPA scans, to see what was the recovery of the native kidney in those who had a simultaneous liver kidney transplant. Interestingly, what they could come out with from their study is the UNOS criteria that's being used currently to allocate combined liver kidney does not really justify the reversibility or the non-reversibility component. There is a good segment that needs improvement in understanding who are the patients who will really be irreversible damage. And hence came the thought process of trying to incorporate biomarkers. So from 2012, of course, this has been going on for a long time in terms of thinking about cystatin and NGAL, but to apply it to a situation where you could look at reversibility of the native kidney following a liver transplant. Biomarkers were one way of looking at it. In addition, this was the similar to the safety net in the US, the Eurotransplant guidelines, which allows for kidney transplant to be delayed and given to patients who continue to have irreversible damage to the kidney after liver transplant. Essentially, patients with liver disease and having hepatorenal syndrome, where you're not sure about the reversibility, go on to have a liver transplant first. And then, if in the next 90 to 360 days, they end up needing a kidney transplant or fulfill the criteria for a kidney, they get additional points. As a result, they are pretty much guaranteed a kidney in the next 1 year, within the next 1 year. So this gave an opportunity, whether it is the right way to go or not, we need some more time to decide. But this gives an opportunity to understand the reversibility component in the native kidneys. So what was the outcome based on applying this criteria? Essentially was that out of the 80 patients, the outcome in the first year in patients who were in CKD either stage 3, 4, or 5, essentially close to about 65% of them recovered their native kidney function. But another important question we need to understand is how much was the recovery? Is a recovery of reaching a GFR of close to about 35, 40? Are we happy with that? Are we happy in the long term? Because we're going to introduce CNIs and it's going to be further deterioration. This is not absolute, but it at least gives us an insight into understanding which is this group that recovers. Had they received a kidney transplant, yes, they would have had a good renal function, but did they really warrant it? So this brings us to the question of when do you really time the kidney after liver transplant? And for that, it is important to understand markers in the future, hopefully, which will help us understand which group recovers as compared to the one which will not recover. Again, this is from Josh Levitsky, who started his work in 2012 with biomarkers, went on to develop this score basically, reverse score, which is based on a few biomarkers, age of the patient, and the patient being a non-diabetic. These were the main factors he took into account. Did an investigation study with this population in Chicago, and then subsequently, he has done the same study with the samples in a biorepository at the Baylor program, where he could take a good population who have had a transplant, but understand what it was to look at these biomarkers in them before and after. So what was very significant was the levels to which the biomarkers dropped following transplant. He divided the patients into 4 categories: partial reversible AKI, irreversible, partial reversible, reversible, and normal, meaning normal renal function, pre-transplant and the post-period. The significant difference in the biomarkers, which was pretty high pre-operatively, showed a good change. The mean difference was quite significant in those who partially recovered and recovered as compared to those who did not recover. So that kind of is probably something that that can help us plan when we want to do a kidney after liver transplant. So essentially, it all boils down to how are we going to optimize using this double resource? And that's why all this thought process goes on. Of course, different forums like the safety net in the US, the Eurotransplant, the Canadian program comes up with guidelines on what to do when we have difficult patients, probably looking into scenarios where we can optimize the organs. For example, recommendations for stage would be when uncertainty exists about the permanence of renal dysfunction, when there is physiological instability relating to the non-renal transplant. And here we talk about post-liver transplant if the patient is unstable, like in Swami's case where he quoted. When there is medically appropriate living donor for one of the transplants, then you could probably do a stage procedure. This is specifically in terms of immunologic. If you're doing the liver transplant to which there are donor-specific antibodies, then it is better to do a stage procedure before putting in the kidney at the same time. Basically, we're talking about every country trying to think about difficulties in this particular domain because the organs are scarce anywhere and everywhere, and more so in our country. So I think if we were to think about what we would do in a deceased donor situation, we need to address these questions about allocation, because these are practical questions that patients come up with when they talk to us. If they don't have suitable live donors, and we are trying to tell them that, we can maybe do a liver now because your kidney may recover, these are all arbitrary terms, unless we tell them that there's a guarantee that if your liver does not recover, possibly you get a priority on the kidney list. So we need to really work towards addressing these issues even in our allocation system, which currently we're not addressing any of these issues. So, having gone through the different scenarios, I really thought I could put forward 3 or 4 of our own patients. I'm going to put up the decisions that we took and the outcomes. And at the end of it, I'm not sure whether we're going to end up with more questions than answers, but that's how it is about combined liver kidney transplant. A 62-year-old alcoholic liver disease patient with hepatorenal syndrome, quite a sick patient. Significant portal hypertension, high MELD, not essentially from the kidney alone, but also because of the liver, because the synthetic function was quite poor. SBPs, recurrent bleeds. So we planned on live donor, 2 donors, combined liver and kidney. At the end of the liver transplant, he was quite unstable. This was several years ago. But I think today's takeaway from what Dr. Swami said and the data on delayed transplant, maybe we could have, thought about. So I'll tell you what we did. Can we proceed with the kidney transplant was the question. So we went ahead and deferred the renal transplant because he was already on dialysis, continued the CRRT in the initial post-op, and then continued hemodialysis. But unfortunately, he just did not recover. He had multiple episodes of sepsis, and ultimately we lost him. So the question is, should we have gone ahead, or maybe in the first 2-3 days? That's something of a new thought, which is not there at that point, to do it in 2 days or 3 days' time. Another patient, very interesting, 61-year-old renal failure following non-steroidal use for knee pain. Interestingly, a renal biopsy was done because he was still he was not in failure, I would say. Initially, it was renal dysfunction. Biopsy was done. This was another center where they had gone and done a biopsy which showed drug-induced injury. Interestingly, had oxalate crystals in it. So genetic studies were done. He had mutation for AGXT. 61-year-old hadn't presented until that time with renal failure or any other symptoms of oxalosis, which, because he didn't have renal failure, oxalosis was not in his system by then. What triggered is probably the drug-induced injury at this point. But now we have a diagnosis that is primary hyperoxaluria. 6 months later, the patient's renal function worsens and he goes on maintenance hemodialysis. What are the options? Do we offer him combined liver kidney transplant because his diagnosis is primary hyperoxaluria? Or do we say kidney transplant alone because he has survived with probably low oxalate production and the renal failure had not manifested until he had this second hit onto his kidney? So we went ahead and offered kidney transplant alone. And again, the discussion was about whether it should be a live donor or should he be on the wait list for a renal transplant. Unfortunately, he had probably an MI because he died at home about 2-3 months on the wait list. 57-year-old with NASH, creatinine of more than 2 for 3 months, HRS with diabetes mellitus. So he does fit criteria for combined liver kidney transplant. He received, and he was on the wait list, received a 26-year-old donor's liver and kidney, doing very well now. He's 8 years post-transplant. Interestingly, DTPA done 1 year later showed 3 functioning kidneys. So did we take the right call? Should we have thought differently? A 3.5-year-old, primary hyperoxaluria, on peritoneal dialysis for nearly 18 months. So he's been on dialysis from the age of about 2 years. On the wait list for combined liver kidney, wait list itself, he's been with us for about 9 months at this point. He had started developing bone and joint issues from the oxalosis, oxalate levels building up, quality of life bad, growth failure. There's no group compatible donor for combined liver kidney transplant from the family. There's one donor, blood group compatible, 58-year-old. So our criteria does not fit to take them as a donor for liver. She could be a donor for kidney. What are the options we had? Can you think about ABOI incompatible liver and kidney from the parent? That was a distant call because you're going to do combined organs, and the whole point is to have a good graft function, and ABOI was a bit of not a straightforward choice. Would be good to get a split liver because that's something our program does a lot. So if we get an in-house organ, or if we get a good organ from the common pool, we could split, give him the liver first, and then subsequently follow it up with a ABO compatible kidney. Or should we wait for a combined liver kidney, given that there's a huge immunological benefit to it? He was one of the lucky ones who got we had an in-house donor, 18-year-old, where we could split the liver and do a combined liver and kidney transplant for him. So again, have we addressed everything? Do we have more dilemmas? I think this is going to persist for a long time. There's not going to be an easy answer. Every time a patient comes to you with an indication or a diagnosis which does fit in criteria for combined liver kidney, the donor options, the waiting time, the individual's presentation, I think will ultimately determine what we're going to offer to them. Thank you very much.
Thank you, ma'am. As always, very clear and vivid concepts. If I may ask Prof to join in, we could maybe have a few questions going back. Prof?
Hi.
Hello, Prof. If I may start with Dr. Swami, I just wanted to know how often do you do a renal biopsy in evaluating whether you need to go out for a combined liver kidney or to go for a liver alone?
I haven't done, or the units where I work, we've never resorted for kidney biopsy. It's more with the other predictive factors and the functional status of the kidney, because as you know, the concerns of coagulopathy and again the reversibility, that there are underlying diseases which will point towards the non-reversibility. Patient may have diabetes or underlying kidney disease. So we've really not done biopsies in all the places where I worked. But again, I don't know if other units practice routine biopsies.
Dr. Gomati, ma'am, what are your thoughts on doing a biopsy? Is there any role?
Yeah, I mean, there has been always, even in the consensus from the 2006 guidelines and subsequently in 2012, the way to confirm CKD in somebody before you were going to give is not just based on proteinuria and a creatinine more than 2, but to have a biopsy which shows significant amount of glomerulosclerosis, the percentage being mentioned 30 to 40, all of that is there. But practically how many programs do is a big question, mainly from the coagulopathy standpoint. But for the sake of argument, in terms of reversibility, if you were to determine studies which did a biopsy, and most of them did transjugular, showed a better way of predicting whether somebody needs a transplant or not, especially in the CKD group.
Would we do a biopsy?
I think, again, it depends on our interventional radiology support. I think our support is quite good. So if there is a clear-cut indication, questions about, donor options, waiting, all of that, it would help with decision-making. Yes.
If I may ask something more operative and surgical, I'll start with Dr. Swami and then I'll go to Dr. Gomati. Like how we look at a CT before a liver transplant, what imaging modality do you look at for suitability for a renal transplant? You look at vessels. What do you look at? I'm sorry, it's a very basic question, but just out of curiosity.
For the liver or for the kidney?
For the kidney, and because we know for the liver,
for the kidney, for the donors, recipient obviously not much to, in fact, you don't really need a CT. All you need is an ultrasound Doppler of the pelvic vessels just to make sure that the vessels are patent enough to plumb in the kidneys there. For the donor, it's a routine is a CT angiogram, and we look at the renal arteries and the number of renal arteries, the number of renal veins, and wherever possible, we try to take the left side because of longer renal vein. This is for live donor. I'm talking only about the live donor. And cadaver doesn't matter, as you know. We can get enough number of vessels, enough length of vessels by either right or left, doesn't matter. If it's a right kidney, you can extend with the cava. Left kidney obviously have a good length. For the live donor, preferably single vessel, long vessels. So CT angio and DTPA to assess the renal functions. Those are the standard imaging studies that we do prior donation. We have a staged, just like liver, we have a staged evaluation. The first step is just the basic routine urine and blood routines. And then we normally do a DTPA to see if the GFR is adequate enough to go further with the evaluation part. A preliminary cross match and DTPA. So if the preliminary cross match is negative and if the DTPA shows a GFR of over 80, then we take them as a potential donor and then evaluate further. Anatomically, we'd like to have a single vessel, but then again, multiple vessel is not a contraindication as long as you are comfortable with what you're dealing with. There are n number of ways we can reconstruct and put the kidney in.
Thank you. Ma'am, anything you'd like to add to that?
I mean, again, having been caught out a couple of times, I think if somebody has, going for a combined liver kidney, has NASH as the etiology, has coronary artery disease, then looking at the iliac vessels in terms of the calcification, sometimes can be really bad. So it's just because you have a choice, because you have the option of choosing between the right and the left, you could look at the external iliac. I do it on the external iliac, but look at the vessels to see the calcification. If you can find a good spot, they have features of peripheral vascular disease. There was one child, which I'm sure Prof will remember, 4-year-old who had on CT had absolutely the left iliac vessels were all collateralized. And so we had to really, that was a mistake in terms of not picking it up on pre-op imaging. As a result, subsequently I had to put it in the abdomen and plumb it onto the right side into the cava. So common things, we look for, but always when we're doing a combined liver kidney, it's going to be a long surgery. You don't want surprises. So it's better to be a little bit more prepared.
Yeah, I remember that case, ma'am, which is why I just wanted to know if that's what we would routinely do or it's something,
I got to be careful with you.
The other question which I think I have asked Dr. Gomathi in the past is like how we do an explant hepatectomy. Why don't we do a nephrectomy? I mean, is there an advantage of doing an orthotopic renal transplant? Like we obviously know that orthotopic liver transplant, has distinct advantages over a heterotopic liver transplant. Is there an indication for doing nephrectomy at all? That's the first question. Is there an advantage of doing orthotopic renal transplant? Yeah, Dr. Swami, Dr. Gomathi, and I would like Prof's opinion also on this actually. Dr. Swami, would you take that?
Well, historically, I think the kidney surgeons are not as bold as the liver surgeons. So they try to find an easy spot where they can probably put in the kidney. I don't know really why, but again, there is no advantage, because it's a small organ. You can plumb it in anywhere where you want, In fact, when I was a fellow in the US, once I was in the middle of the night trying to do a kidney transplant, and as a second-year fellow, opened up. I couldn't even. This guy was on the waiting list for 5 years. And he just walks in the middle of the night for a kidney transplant, and I opened the pelvic area. I couldn't, right from the beginning, there was a lot of collaterals from the subcutaneous plane. Then I entered the pelvis and I couldn't find an iliac vein. I kept on extending my incision, the modified Gibson incision or the reverse hockeystick incision. And I could not even see a cava or even the common iliac vein. Then I called my boss. He came and then we realized, we called intraoperative ultrasound. We found there is no cava. It's all completely atretic. We didn't have a space to put the kidney in. Then we had to put the kidney higher up, use an extension iliac graft to plumb it to the aorta, and plumbed the venous outflow to the portal vein, to the SMV, and did a ureterostomy over a stent. So that was like, so from there I realized that you just need one inflow, one outflow, and the ureter has to be somehow connected to the bladder. You put it upside down, you put it however you want to put it in, but then it just needs an inflow and an outflow with the ureter connected to the bladder or somewhere so that the urine can go out, you don't really need to knock the kidney out, because that itself is a complex procedure. And the simplest way is just implant wherever it is easy. I think that's why it's been chosen like that, I guess. And there is no advantage.
To make,
Sorry?
Dr. Pari there. No, I can see Dr. Pari has a point to make. That he's been raising his hand for a while. So go for it.
Yeah, hi Sami, hi everybody. Yeah, one of the important things to consider in kidney transplant is the graft kidney gets the graft kidney's ureter gets blood supply only from the lower polar renal vessels. Unlike the native ureter, which gets supplied from the small unnamed vessels from aorta, common iliac, and from the bladder. And here, the ureter gets supplied only from the lower polar renal vessels. So you need to keep the ureter length as short as possible, just enough. So you really don't, you're not looking at having a long ureter, placing it in the orthotopic position, having a long ureter. The tip of the ureter will be ischemic. So it really doesn't make sense to put the kidney in the orthotopic position. You really rather want it to be closer to the bladder so that the ureter you got is as well vascularized as possible. Probably that's one of the reasons why you put it in the iliac fossa.
Ashwin, in children, when we do for ARPKD, if space is a constraint because of the kidney, we did that once in the last 2 years, 3 years, whatever, where we had to do a native nephrectomy because the kidneys were so large, and place the kidney. This was a 9 kg child, and place the kidney right there and anastomosed it to the aorta, actually not the renal artery, but to the aorta itself. And also Matthew had a paper quite recently where the child was, I think, like 6.8 kgs or 7 kgs, where they had to do a combined liver and kidney, primary hyperoxaluria. So they used a left lateral graft, and for space, they removed the right kidney and put the transplanted kidney intra-abdominally there. So it's not a routine, but every now and then, yes, you can think of ways to do it when it's required.
But how often is a nephrectomy required? It's only rare indications like an ARP.
Sorry.
Native nephrectomy, there are specific indications for that in transplant patients. I mean, if they have malignant hypertension, if they have polycystic kidney, which you are suspecting a tumor, or if there is hematuria, recurrent UTIs, infection in the cyst, proteinuria. So there are specific indications for a native nephrectomy, not necessarily for space requirements.
Prof,
Ashwin, yeah, I mean, we have done nephrectomies, as Gomati said, for very large kidneys. So the adult polycystic kidney disease, sometimes they're so large that there is no space because they are pushing down below. What I want to ask, I think Gomati may have an experience with this. The other reason to leave the kidney behind is also that there is some residual function in the kidneys. If there is some residual function, why do you want to do a nephrectomy? The only worry is whether, these atrophic fibrous kidneys, what is the risk of malignancy in them? I think Gomati will know the example. There was a transplant surgeon who died of renal cell carcinoma in an atrophic kidney. How often does that happen? I don't know. Because then he never had symptoms, no hematuria.
Yeah.
Pardon?
Yeah, I mean, atrophic kidneys in terms of totally non-functioning kidneys like he had, I think the incidence is extremely small. I mean, he was one unfortunate one, but this is not anywhere documented as one of the indications to go ahead for a native nephrectomy or even keep them on surveillance. So I really don't know if there is any literature to support that.
Okay.
Any thoughts on Outflow obstruction, Prof. If you would have a heterotopic liver lower down on the cava, then you would have venous outflow obstruction in the long term. Why do you think it doesn't happen with the kidney? Is it because of a higher flow per gram? Is there a reason?
You mean outflow is not a common problem in kidney transplant. I always say that about pancreas transplants because see, the pancreas is implanted on one side and the kidney is implanted on one side. You do an extension for the portal vein for the pancreas. But the incidence of pancreas thrombosis, venous thrombosis in pancreas transplants is very high. And I used to do pancreas transplants in the very early days in King's. The only reason I've always postulated is the amount of flow for the mass of the kidney. There's a huge volume of blood going through the kidney and through the renal veins. Whereas for the size of the pancreas, which maybe weighs exactly the same as a kidney, the blood flow is probably 1/10 of what is going through the kidney actually. And therefore, there is a very sluggish flow on the venous side. On the splenic vein along the length of the pancreas. There is hardly any flow because most of the flow that is going through the venous side behind the pancreas, draining the pancreas, actually the splenic flow. And in a pancreas transplant, you take the spleen off, and this is a large splenic vein draining the pancreas into the iliac. The thrombosis, as you would expect, is very high. And that's why I think the venous thrombosis in kidney transplant is much lower. And in terms of position and everything, it's not an issue. Can I make a comment? Because the talks, both of them were talking again and again about utility, really. How this is a nephrology view. Nephrologists are only concerned about their patients, obviously, to give kidneys to their patients. So they're not worried about whether a liver patient dies or survives. So it's always, as Gomati said, when you do a scan later on and find that there are 3 functioning kidneys, it's looked upon in horror that you've transplanted somebody who did not need a kidney transplant. Now, there are 2 ways of looking at it. I think Swami showed in the very early slides that if you transplant somebody with severe renal impairment, the survival is much poorer, probably in the range of 20% below what you would expect for a liver transplant. Now, the poor renal function at the time of transplant doesn't mean that the kidneys are not going to work in the future. We are only talking about getting the patient through the perioperative period. And in the perioperative period, those 2 kidneys that they have do not work. And if they require dialysis support in the perioperative period, the mortality is 15 to 20% higher. So it doesn't matter if their kidney is going to work in the future or not. What we are transplanting as a combined liver kidney transplant is to get them through the operation. That's one view that I've always had. And the second view, in this process of thinking that this kidney is going to work and I'm therefore not going to do a kidney transplant, I will only do an isolated liver transplant, you lose 15% of the patients out of 100. You're losing 20 grafts, which could save another 20 patients in the cadaver setting. 20 liver grafts you're losing because of the death of the patient. So I don't think it makes sense to say that just because people have demonstrated after a year that the native kidneys have started functioning, these candidates have had a kidney transplant in vain and those organs have been wasted. I don't believe that at all. And maybe in the future, you should be thinking about taking that kidney out, consenting them and giving it to somebody else in the future. They'd gladly do that if that will make them survive through the operation, really. I think that argument is really flawed and not the right one, because we are talking about getting them through the operation. We're not saying that they won't have renal function in the future. And just not having the renal function will make a significant proportion of those patients die. And that is why I'm also against the principle of delayed renal transplant is one thing. After 2 days, 3 days, that's another thing. But to do a sequential renal transplant in somebody who requires kidney and liver transplant is a problem. Because when there are situations in the living donor setting, particularly, when a patient requires a combined liver kidney transplant, and they've got only one donor, and if it's an adult patient, they donate the right lobe, and sometimes we have told them, we put them on dialysis, and then 3 months later, when their liver is fully regenerated, they can donate donate a kidney. I've done that before, actually. Successfully, we have done that. But again, you're risking a higher mortality perioperatively for these patients just by giving the liver alone. And therefore, it's better for them to come up with 2 donors where you do a combined liver kidney rather than go for a sequential liver and kidney. The only situation where I would still buy the option of liver and kidney, sequential liver and kidney would be the hyperoxaluria, really. Again, there is also, but these patients actually don't have liver disease. They're not very sick. And therefore, it may be easy to pull them through the operation without, even with dialysis perioperatively, and then offer them a kidney transplant 3 or 4 months later. I don't know if people have understood the reasons of the recurrence. I mean, there are many points that we can talk about. Maybe I'll ask people to ask questions. One of the problems of the combined liver kidney, we have done that in a cadaver setting. If you're going to do a primary hyperoxaluria cadaver liver transplant, there is clearly, as Gomati said, there's an immunological advantage, and therefore you do a combined liver and kidney transplant. Then what happens to the kidney? That kidney can be affected. So we put them on a very, very aggressive dialysis. You can't even prepare these patients with dialysis preoperatively because cadaver organs can come any time. And therefore, we usually put them on aggressive, continuous hemofiltration for about 3 to 4 days, even when their kidney function is, kidney graft is working. Sometimes, I think quite often we can get away without the new kidney being overloaded with oxalate. What happens when you put a new kidney in somebody with hyperoxaluria is, so gradually, if they lose their renal function, and when they lose their renal function, the only way the oxalate crystals gets excreted from the body is through a functioning kidney. So as the functioning kidney stops working, the body keeps, the oxalate gets loaded up in the body, and most of it is actually stored in the bones, which is why they get fractures, they get osteoporosis, because it demineralizes the bone, and the bone is replaced with oxalate, actually. And also it can store in other organs, and they all have severe cardiac impairment, and which is why the outcome of combined liver kidney for oxalosis has been poor, because their cardiac function is also very poor. And actually, aggressive dialysis preoperatively can take away the oxalate crystals. The only other way of taking the oxalate from the body is by dialysis, actually. So these patients require much more frequent dialysis to remove the oxalate crystals from the body. So when you put a new kidney, all the oxalate which is stored in the bones get demineralized, and the kidney starts working. The oxalates keeps moving out of the body through the new kidney, and the new kidney can get overloaded with oxalate very, very rapidly, sometimes within weeks and the months, and then the new kidney can fail because of the mobilization of the oxalate. At the same time as the oxalate is getting mobilized from the bones, these patients will get fracture. We have had patients who have had fractures immediately post-operatively when we have transplanted them for hyperoxaluria. So I think the best way to manage these patients is probably do a liver alone and then dialyze them. Once you have replaced the liver, there is no more oxalate production by the liver. So the factory where the oxalate is produced stops. So you dialyze them and remove the excess oxalate from the body. And that's why the serum oxalate level doesn't help, actually. Because most of it is stored in organs, and as you remove the oxalate, it gets removed from the storage areas, and then when the total oxalate level in the body comes down after 3 months, you do a kidney transplant, and it is safe to do that. I'd like to make one correction that Swaminathan said. He suggested that in the early phase of hyperoxaluria, if we know from the family history, we could do an auxiliary liver transplant. Actually, auxiliary liver transplant is absolutely contraindicated in primary hyperoxaluria. It's contraindicated in all conditions where there is a byproduct, where there is a production of a substance like amyloid or like oxalate, which affects other organs. Because if you do an auxiliary liver transplant in these patients and keep a part of their liver, half of their liver still in, the remaining half of the liver will continue to produce oxalate. This is not like other metabolic conditions where there is a missing enzyme and the auxiliary liver substitutes for the missing enzyme, and then as in the blood recirculates through these auxiliary livers, the metabolic defect is corrected. It doesn't happen like that in hyperoxaluria. It doesn't happen like that in FAP, that is familial amyloid polyneuropathy. In all of these conditions, actually, it is a contraindication because the remaining liver will continue to produce the oxalate, and therefore it doesn't work. There's one other question that I want people to think about is, would you use these livers as dominoes then? Because if there is somebody with a HCC, for instance, who is borderline for transplant or slightly outside the criteria for liver transplant, by doing a domino, we know from the amyloid polyneuropathy, the disease FAP, I don't know how many of you know about familial amyloid polyneuropathy, which is also a metabolic disease where amyloid is produced in the liver and deposited in the peripheral nervous system. And they usually die of really neuropathy, peripheral neuropathy. And the disease process takes about 30 years, whereas it's much shorter in hyperoxaluria. And so you transplant, we did one of the very early transplants for that, maybe 30 years ago, actually. If then at least you will know, you give them an FAP liver, and if they've got no recurrence of HCC after 5 years or 10 years, and when they start to manifest the symptoms of familial amyloid polyneuropathy, you can retransplant them. Now you've given them a chance of 10 years of survival and the possibility of retransplant, instead of telling them that they're not candidates for liver transplant and allowing them to die. Can that happen with hyperoxaluria liver? Because these are non-cirrhotic livers, they're completely healthy livers. You can potentially put it into somebody who doesn't have hyperoxaluria, and it takes a long time for the hyperoxaluria crystals. I mean, even if it gives them 1 or 2 years for the new kidney, maybe you can diurese them, you can force diurese them throughout, give them a lot of water and things. Whether these livers can be used as a domino liver for HCC is a question that needs to be explored. I did do one some years ago, and unfortunately, within 6 months, the patient lost the kidneys, his own kidneys, due to crystals in the new kidney. So we don't have an answer for that, but that's an interesting thought process as well. I don't know if Gomati has data or knows data about.
No, Prof. I read a case report on this of very early loss of renal graft following using a hyperoxaluria. So the hypothesis suggested was there is an additional CNI toxicity in addition to the oxalate also, which probably accelerates the renal injury in these patients. I mean, that was just a hypothesis from that case report, actually.
See, because, yeah, go on.
For the point you mentioned about auxiliary partial will not be helpful or in fact contraindicated in oxalosis. My understanding is, or rather, the pathophysiology is basically the enzyme deficiency. So leaving behind a part of the liver and giving even a left lateral lobe would probably correct the enzyme defect.
It doesn't. It doesn't. I tell you, I promise you, it doesn't. It's written enough, and I have written this maybe in 4 different publications. The mistake was done by Gomati's ex-boss in Baylor, where they felt they had the same thought process as you. In fact, when that paper was published, I compared a paper published 6 years before they made the mistake, and side by side, I put 2 slides to say where I have said it's contraindicated, and then Baylor went and did the experiment and then concluded it's contraindicated.
Okay.
So you cannot do, because it's not an enzyme defect. It's an abnormal production within the pathway that cannot be stopped by replacing the enzyme. So you just need to go into the metabolic pathway of how oxalates are produced, and you'll work it out yourself. And it's the same with FAP. You cannot do that. They're not enzyme defects. These are.
Okay. No, I was thinking more like the urea cycle defect, where you can like domino or exchange the left lateral lobes and similar.
Yeah, but the process will keep on happening within the native liver as well. So the oxalate crystals will get produced within the native liver. That keeps happening. Anyway, it's been done, and the hypothesis is proved that you cannot do it.
Sure.
Prof, if I may just add about FAP and primary hyperoxaluria, why a domino wouldn't be is because of the rapidity of production of the oxalates. While in FAP, they've shown that it still takes, it's quicker after a transplant.
Yeah, but FAP normally manifests itself when somebody is 35 years of age. So they've had 35 years of that liver before it causes clinical symptoms. Okay. But post-transplant, in fact, I published on that. I think I put in our domino FAP liver for the first time in the UK. Probably around 30 years ago, I think. I still remember the name of that patient. That guy, so once we were part of the amyloid unit, actually. The Royal Free was the National Amyloid Centers, and they referred amyloid patients to King's College Hospital. Even though Royal Free had a liver transplant program, they had a huge faith in us. So we worked very closely. We have a number of publications on FAP. We found that this patient, because we started doing amyloid scans on him every year post-transplant, by year 10, he started having amyloid deposits in the peripheral nerves, actually. And we retransplanted him 10 years later, so he doesn't have any neurological problem. So technically, yes, it seemed to be coming slightly earlier than you would. But just demonstrating amyloids within the nerve 10 years later doesn't mean that he would still get the disease. He might take another 10 years for him to get the manifestation of FAP. With respect to hyperoxaluria, I'd just like to say, even in family situations, I know Swami said you cannot do a kidney transplant in these patients, but there are still some centers who say if you make a diagnosis early, and if you knew the diagnosis, you do a kidney transplant, and then you diurese these patients regularly and increase their fluid intake, you can actually keep their kidney for much longer. I don't know. There have even been reports, I think, of kidney grafts surviving for 10 years in these patients. So if you know that you have transplanted a liver, a domino liver, it takes a long time because again the storage happens and it takes a much longer time for it to do. But I don't know. But I know that in Pakistan I used to help those programs, and we actually did a domino of an amyloid liver into a HCC patient, like I said. 6 months later, he lost his kidney function. But he was still grateful that he was given the opportunity to have a liver transplant for advanced HCC, and he did not get recurrence of the HCC. I did not follow up. I think he probably had combined liver kidney transplant afterwards or not. I'm not sure about it. But it does seem like that the hyperoxaluria liver, when you do an domino, destroys the kidney much sooner than you would expect it to.
Sure, Prof.
Ashwin, can I pitch in?
Yeah, yes, ma'am. Sure.
No, I just thought I could, because all the, most of the programs are represented here from Tamil Nadu. I thought I could take this opportunity to bring back the discussion to our state, our allocation systems, and see whether we can all get together to think about, allocations for split, for pediatric donors, because the children that I presented, I mean, the problems we were having in waiting for him for close to a year was because of not being able to get a pediatric liver. And if it does, not just a pediatric, a good quality, which can be split, could be somewhere else. And then what happens to the kidney? So I think we need to get into discussions to try and evolve our allocation system a bit better. That would help more patients, I think. This is an appeal to everybody who's here.
Dr. Pari, you have a comment to make.
Gomti, I think we have people from everywhere, including from abroad. I don't think it's the right forum to talk about the allocation for Tamil Nadu. My humble suggestion. Second thing is,
I'm sorry about that.
Yeah, and second thing about the kidney-only transplants for hyperoxaluria. I guess there are some patients with the type 2 who have a much lesser severe disease. These are the patients where kidney-only transplants have worked because the oxalate load and the severity is much less. And there are several publications where kidney transplant alone has worked in type 2 hyperoxaluria. Probably those are the cases which probably we were referring to, kidney alone.
Yeah, probably. But I think this literature is quite old, actually. I think now, everybody's quite accepted that for type 1, it needs to be a combined liver kidney. The point again about preemptive liver transplant without kidney transplant is also quite a difficult one. Because how long it takes for somebody to develop renal failure is also very variable between one individual to the other. And there are people who argue that if you do preemptive liver transplant on somebody who may not require a kidney transplant for another 10 years is an issue. So that's also there.
Sure. I have an ethical question which I thought I'll run by all the panelists here, and it's something Prof and I have discussed in the past. Now, especially in our setting where we have LDLT donors, and we do sequential combined, sequential liver kidney transplant, do you accept a post-renal donor as a liver donor? Like what Dr. Gomati said, I mean, we have done post liver donors as a renal donor and sequentially, and like what Dr. Swami said, you can do it simultaneously as well. But how often is it to find a post-renal donation liver donor, and would you accept on an ethical standpoint? Dr. Swami, Dr. Gomati, and I would like props.
Talking about from the same donor?
Yes.
If it's a left lateral, then I guess it's doable with a left lateral lobe and kidney.
Let's make it a right lobe. Let's make it harder.
Yeah, let's make it a right lobe. See, again, not sure because I haven't done it, and please definitely I'd be very worried to do it as a single procedure at the same sitting of right lobe and kidney. It's definitely not my piece of cake, and I'm not sure. Maybe some high volume centers, could do that, but I certainly can't comment on that. But I would prefer two different donors for a right lobe and a kidney because it's too much to do in a single patient.
Interestingly, I'll just add some background to this question. While I was doing a literature search, I found a series of 15 patients from Lisbon unit where they were previous kidney donors and they have safely done a right lobe. So
yeah, I thought that was a question you were asking, not a combined liver.
it was also the question. Yes.
Yeah, I will not do a combined liver and kidney donation for right lobe donors, but I'd comfortably do it for a left lateral segment donor. So in pediatric setting, you could actually take a left lateral segment and a kidney, but not for the adult segment. But see, I said that earlier on, we did a right lobe donation and then considered that patient 3 months later for a kidney donation when the liver is fully regenerated. I would have no problem with that. I would have no problem with a kidney donor who has already donated the liver and fully recovered from it. But I'd have a huge problem with somebody who's donated a kidney. So let's forget about whether they are donating the kidney for the same patient or not. So if I have a patient who comes to me who's had an nephrectomy for a right lobe donation, I wouldn't consider them because they don't have a normal renal function. To me, they wouldn't be candidates for a right lobe donation. So, because one little thing going wrong with a right hepatectomy with a single kidney, it's a huge problem. And then if they require dialysis or something, you're unnecessarily increasing the perioperative risks for that donor. So in my view, I know Liz is a good friend of mine, but in my view, if somebody's donated a kidney, I'm not talking about a single large kidney. I mean, there are some people who have a congenitally single large kidney with perfectly normal renal function. If somebody has actually had a nephrectomy, I will not consider them for a right lobe donation.
Dr. Gomati, would you like to?
No, I agree with Prof because I think it's liver, we say after a donation, your liver functional capacity comes back to normalcy with your regeneration. But when you lose a kidney, you've lost a certain number of nephrons. So essentially, there is going to be your renal function is not the same. So even long-term studies on renal donors, they are not the same as long-term studies on liver donors. So once they've donated a kidney, they do have compromised renal function, and so they cannot be considered for a liver transplant. I think this is what probably been with Prof for a long time now. The thought process is the same.
Right.
I think the other way of looking at it is the greater chance of the recipient dying during the procedures is complications related to the liver transplant. So if you do the liver transplant alone first, and if for any reason the patient doesn't make it, at least the donor doesn't lose the kidney. So the patient liver transplant went off well.
The simultaneous you're talking about.
Sorry?
For simultaneous combined liver.
I'm talking about the same donor giving liver and kidney. I would rather just do first liver rather than. That's what I mean. Liver only first. Make sure the recipient, went through the liver transplant went well, and then probably you can think about transplanting the kidney, rather than the other way around.
No, with regards
yeah, that's true. I mean, that is absolutely right. You cannot do it the other way around. If somebody requires a liver transplant for renal liver dysfunction, if you do the kidney first, they will not survive the operation.
True.
They'll get decompensated liver disease and die. You could actually get away the other way around. The other way around, if you're talking about what, transplanting in 2-3 days later or transplanting 3 months later?
I would rather transplant it several months later.
The problem with that is if somebody requires a liver and kidney together, if you do liver alone, you're looking at a 10 to 15 or 15 to 20% reduction in the survival.
True, Prof. Is there any difference if the patient has a the native fistula or a HD catheter for dialysis? Because we are looking at the sepsis from the dialysis related sepsis. So is there any difference if the patient has a fistula, where the dialysis?
Yeah, there may be. I think fistula may be slightly more advantageous than having dialysis catheter. I agree with you for septic complication. But just the fact that they are having a dialysis and an extracorporeal system going on actually makes a difference. You will find that the incidence of reoperation for bleeding is extremely high in patients who go on perioperative dialysis. There are situations where people have had multiple reoperations when they have renal impairment and their platelet function is poor. And we are talking about very sick patients. I mean, a chronic liver disease patient with renal impairment, with chronic kidney disease, coming from home for a transplant may be very different from a patient who's sick in hospital in ICU who requires a combined liver kidney transplant, or an ACLF which requires a combined liver kidney. These are all really very sick patients who will not make it really if their renal function is not good and they go on dialysis.
Pari, just to answer that question, again, the immediate renal function is something very important in the post-operative period. So I'm getting more and more attracted by the approach of kidney transplant done within 2-3 days after the liver transplant, wherein you maintain the patient only for the first few 48 hours until the hemodynamic stability is achieved, and you're fairly confident that the patient is stable, off inotropes. The vasodilatory effect of the cirrhosis is all to somehow nullified by the new graft, the new liver graft, and then you put in a very good quality live donor kidney. That will help them to recover much faster because of the fluid management becomes easier. When you have a functioning kidney, the fluid management becomes much easier, and fluids, electrolytes, everything manages easier. The liver graft also goes much quicker than keeping them on a CRRT. There is nothing like a functioning kidney. So I think that there are not just one paper. There are quite a few papers now about this delayed kidney transplantation within a few days of liver transplantation to get them off the CRRT as quickly as possible.
I think I agree with that. Actually, slightly delayed is useful, because if there is a very sick patient who becomes sick perioperatively, you put the kidney is also damaged. And the delayed graft function. Delayed graft function is actually as bad as not giving them a kidney transplant at all, because you lose the benefit of having a good kidney function immediately after the operation. And I think Gomati also showed that data. Delayed graft function actually removes the benefit of a combined liver kidney transplant.
Dr. Gomati, do you think we missed that trick in the first patient you did?
Yes, I think so. I think so. Okay. No, I think so. We actually looked at it that he was very sick. So the decision not to go ahead with the kidney transplant at that point, I think, was the right one, because you would have risked, putting another donor through a surgery and the graft. And first 48 hours was really crucial. But being able to go in the first 2-3 days was not a thought process we had then. I agree.
Ashwin, Ilango has a question.
If he can switch on his camera.
Ilango, yeah.
Dr. Ilango, go for it.
Ashwin, thank you. Nice talks by both Swami and Dr. Gomati. So I wanted to just touch base with you on a few things. What's your GFR estimation technique in ESLD, which you're practicing now? Am I clear?
Dr. Swami and Dr. Gomati can take it sequentially, not simultaneously.
Lingo, we do a DTPA scan mostly for these patients, and we get a proper estimation, which is probably the easiest thing to do, non-invasive thing to do at the moment.
Dr. Gomati?
I think we don't go just by GFR. I mean, eGFR is what we do, but we look at all the parameters put together. We look at cystatin also on our patients. We look at the eGFR, the kidney size, proteinuria. So all of these put together is how we take a call.
So we were taught to use the MDRD6 equation in Pittsburgh. Pari trained us to do the GTP renogram. But recently I found the Royal Free Hospital has a good calculator now. Did anyone try this?
No, we've not.
Royal
No.
Free has a calculator for ESLD patients, and they say that the MEL score goes up because the underestimation, the overestimation gets corrected. So they have put up that formula. So that was one question. And the second question is to Swami. I'm surprised that you said you don't do a cross match for your when you prepare for a simultaneous liver kidney transplantation. Why would that be? This was our protocol. We do the PRA, the HLA class 1 and 2 antigen, and the B cell and the T cell cross matches. They will all be there. The only difference was we used the same kidney transplant protocol, immunosuppression for CLKTs, and then we used to give the thymoglobulin post-transplant. That was the only difference. Any change in your protocols?
Are you talking about cadaver setting or live donor setting?
Cadaver setting.
Cadaver, we don't have the luxury of having a full characterization of donor. So you need a donor HLA, at least if not all the 8, you don't get any data about the donor. So how would you can do a preliminary basic CDC cross match because the flow takes somewhere about even with the best of the labs here in Tamil Nadu, the flow takes somewhere about 12 hours and single antigen takes somewhere about 2 days. So you're not going to get the results prior to transplant. With the CDC cross match, which is very crude, and again, you're not going to, the immediate graft outcome is not going to be dependent on the amount of pre-formed antibodies. We all know that class 1 antibodies are very well handled by the liver. It's only the class 2 and the DSAs. And you're not going to say, if, for example, let's say a hypothetical situation, you're doing a cross match. If you're finding a B positive, flow B positive, flow, I don't think an Indian setting would be able to get a result but before you can plumb in the liver or kidney. Let's say in a CDC cross match, or if you're doing a PRA, if you have a PRA status of your recipient well ahead of, let's say you're of very high PRA, and at the time of transplant, if the cross match is T negative but B positive, would you go ahead and transplant or would you not go ahead and transplant? So, I would still go ahead because it's a B cross match, and we know that the liver can handle it, even if it's a T cross match. The class 1 antigens are very well handled by, because the liver secretes a lot of soluble class 1 antigens, which can neutralize most of the class 1 antibodies. And if the class 2 and if the B is weakly positive, you will still not have enough time to treat the patient. You're not going to exchange the patient, or you're not going to consider rituximab in these kind of patients. So you need to, and there are enough studies to show that all these class 1, class 2, even the DSAs go down substantially after the implantation of the liver. They've done some serial studies of antibodies. So we haven't really done any antibody profiling in the recipient unless it is a living donor. That's what I mentioned in my talk also. If you do a liver from a cadaver, and if you're going to do a kidney later, then you have an opportunity of doing a complete characterization of antibodies, and then you can probably pre-treat the patient before plumbing in the kidney. So you can prepare the patient immunologically very well. But then again, that's going to be 2 different donors. You're going to expose the patient to do 2 different sets of antigens, and the immunological advantage is partially nullified there.
But you can still do a CDC cross match, isn't it, in these patients?
That's right.
That's my base question.
But then transplanting a combined liver kidney across a positive cross match is not a contraindication. In fact, they don't go for a hyperacute rejection at all. And again, about thymoglobulin, I haven't used thymo for a combined liver kidney. We've always used Similac as a maximum induction for that patients. And it's I think it's a bit more complex than just preformed antibodies and their impact. I agree that definitely they do have an impact on long term, particularly the class 2s, and more and more interest are now emerging towards class 2 antibodies and their impact on and the DSAs and their impact on liver and kidneys in a combined liver grafts. But then that's something that you can handle after transplant. Obviously, we are not going to see a hyperacute rejection of liver or kidney, even if you transplant across cross-match positive couples.
Prof, can I ask you a question regarding this?
Yeah.
The two bad antibody-mediated rejections in the liver for live donor transplant, which I saw in Pittsburgh, they all had this positive cross matches, which we were not bothered initially. So that is my concern. What would be your thought on this? Avoiding it.
Guys, you know more about kidney transplants than I do. But let me tell you something. We have never done cross-match for combined liver kidney transplants when they come in the cadaver setting, when they come from the same donor. We had a kidney transplant surgeon who used to work with us who did the very early studies on the preformed antibodies and said that they rapidly disappear within hours, actually, within 1 to 2 hours of reperfusion of the liver. So I don't know, and I think Swami seems to know a lot more about this literature than I do. So I was a little surprised when you asked this question that why you're not cross-matching. We have not done that even in Chennai. I don't know, Gomati, does she want to answer that?
No, we don't do that. We don't do that. We don't do cross-match.
I'll take it one step further to say that before I left King's, we had a proposal some 10 years ago that one of the problems with these highly sensitized patients was that they were never going to get a kidney transplant. And we had a proposal that we will do an auxiliary liver, left lateral segment auxiliary liver transplant for them to absorb these antibodies and then do a kidney transplant. And we also promised that these livers may not be wasted because you can actually take the left lateral segment from these patients, from these kidney patients, and offer it to a child instead of offering the first part of the split. You exchange the left lateral segment and then giving it to somebody else. So the left lateral segment, in fact, is not wasted. So I think there is now literature on that, but I've not actually read it recently. But I'm sure that some people have done a liver transplant as an auxiliary and then done the kidney transplant in highly sensitized patients.
Yeah, yes, I think there's a publication from the Swedish group about that auxiliary partial exchange transplant that you described, recently published to tackle.
Yeah, I mean, I proposed that 12 years ago, actually. We never managed to do it because then I wasn't regularly going to King's, and that just fell apart. But I knew that somebody was going to take it up and do
it. The last question is, we had a habit of putting all these kidneys on the life port, and we only when the liver is stable, when the patient is stable, we put the kidney, we plug in the kidney. Otherwise, we were doing it routinely a little later, second or the third day. I didn't find anything abnormal at that time. I was just following the protocol in Pittsburgh. And we used to check the life port flow for 100 and a pressure of around 15 to 40. And we used it. And I found most of the kidneys worked very well. But we had a rule that the kidney has to be pristine in a CLKT. Where did this thought change that you can accept high KDPI kidneys? I mean, when you plug in the kidney for a CLKT, it should work immediately was what we were taught.
That's a thought process, Ilango, but in real world, you don't get that opportunity. So you can't pull out all the young kidneys and give it to a combined liver kidney. And that means that, there is another group of nephrologists who are looking at the life years derived from kidney transplant, the net benefit of transplant. So, there are some seminal papers about putting in losing a lot of young kidneys on marginal patients. Basically, you're losing a lot of life years from kidney transplant. So that's why the allocation took a big change about the Euro Senior program, the age matched allocation programs, and when all those things came, see what they found is even with the higher KDPI kidneys, if you can keep them on the pump, and if you have an acceptable pump parameters, and you transplant them, you still can avoid in fact, other than Indiana, there are few other groups who've done the same approach of delayed kidney transplant using high KDPI kidneys, and showed that the DGF rates are virtually nil. Because I'm talking about ECD, DCD kidneys.
What would they do? I mean, I read the paper too, but they have not mentioned what they did when the pump parameters were not good. Did you find anything like that?
No, that's not obvious in the papers, and obviously they wouldn't have chosen the extremely marginal kidneys. That's where as Dr. Gomati mentioned about the dual kidneys, where you have an extremely marginal kidney where you think it won't be, even on pumps it won't fare well. Then you're probably thinking about giving a dual kidney with a liver. But then this in-between group with a KDPI of 30 to 60, the marginal kidneys, if you can effectively use them, those are the marginal kidneys which cannot take any more injury. When the liver transplant happens, there is a lot of hemodynamic instability intraoperatively as well as in the immediate postoperative period. So cool the kidney, keep the kidney on the pump, let the patient settle down, coagulopathy settles, hemodynamic stability achieved. Then you have a very controlled environment where you can go in and pump in the kidney, and you can pretty much avoid even a well pumped. That a well pumped DCD ECD can function straight away if the kidney transplant is done swiftly in a stable patient.
Thanks, Swami.
We've been at it for 2 hours. If I may just ask one question, which I would like Prof's opinion as well. It's with a view into the future. Now we know robotic renal transplant is a reality. In fact, we had a robotic webinar from Chicago where they did show the whole procedure robotically. We also know that maybe in 10 years, robotic liver transplant might be a reality. How feasible do you think is to combine the two and have a robotic combined liver kidney transplant? Do you think it's useful at all? Dr. Gomati, if I would like your opinion, then I would like Dr. Swami.
I think Prof is the one who can answer that because he's been at the robotics now all the time. So,
Swami,
Ashwin, I think robotic kidney transplant, in my personal opinion, will become a standard of care in near future because I've seen it. I never believed until I saw that. And I spent a couple of days with Pranjal Modi doing robotic kidney implantations. It's fantastic. It appears easier than an open kidney transplantation, and it's quicker. And the anastomosis time is literally 20-30 minutes. It's intraperitoneal though. So if you can get the tricks, if you get the skills, then I think kidney transplantation should be done robotically. It just goes in through a small 5 centimeter Fanon steel incision, and it takes literally 2 hours to complete the anastomosis, including the ureter. The entire kidney transplant procedure is over by 2 hours, and that is definitely going to be a future. And maybe I don't know how many of them will pick it up, but definitely robotic kidney implantation. A lot of centers has picked up already, and I think everyone has to, go towards that. And again, robotic donor hepatectomies and lap nephrectomies are becoming very standard now. I'm not sure about the robotic liver recipient hepatectomy and implantation. It looks like a bit far-fetched dream for me, at least, who's still, still trying to learn robotics here. So.
You have any words to say, Dr. Pari?
Yeah, same as Sami. For me, other three things probably will pick up in future. But robotic explant and implantation of the liver. I mean, I really have to stretch my thought. I have to really. It looks really too far away from right now.
It's actually something we are working towards. Now only we have started lab mobilization in the recipient so that, we can reduce the size of the incision to a, midline. Yeah, I don't know if we can go there. Prof, what are your thoughts on that?
Yeah, I don't believe it's far-fetched actually. I think it is. I think the instrumentation needs to improve. I think, which I think we can improve. If vascular anastomosis can be done in kidney transplants, there is no reason why vascular anastomosis cannot be done. It's probably easier to do the segmental grafts. It's probably possible to do children because you can clamp the cava without very easily. And I think it can be done right lobes. Maybe a whole liver may be a little bit more difficult. Thinking about axis and how we do the anastomosis, I think it's not far-fetched for me, and I hope that I'm hoping that in 6 months' time or in a year's time, I do a child first. I think we are working on that, and I think it is going to be there. We all need to think about the safety first. It's not about that you can do a technique. It needs to be reproducible and it needs to be safe all the time. I do believe that if the instrumentations change, it can become safe. And I'm sure it will change, and it's going to be there.
Thank you, Prof.
I'm sure Swami knows as well. It actually makes the operation much easier. I did the first left lateral segment mobilization, and it was as though it was like an open operation. And I think within 4 weeks of starting, I've never done minimally invasive surgery, and within 4 weeks of sitting in front of this console, we were able to complete an entire donor operation.
Congrats, Prof. That's something tremendous, because I mean, robotics, although it's easier than lab, still it requires a lot of hard, training hours. For me, I felt like.
Yeah, the coronavirus gave me the training hours. So something positive came out of COVID, actually.
Yeah.
So I was practicing a lot. I think I was practicing in for almost 18 hours before I started operating.
Yeah, I completely was awestruck when I saw kidney transplant done by robotics, and that's when I felt that it's actually much simpler to do robotic implantation than an open implantation.
I think for obese patients, it's actually true.
It is, yeah.
For obese patients, it's easier to do robotically than open.
Yeah, as you said, it might catch up in the left lateral lobe where it is. There is a lot of space to implant.
Yeah, I'm sure.
No problem.
Okay, guys.
All right, thank you.
With that, I think we'll close this session. We've been again at it for 2 hours now. Dr. Gomati, thank you so much. Dr. Swami, thank you for joining us from Australia in your quarantine time. And Dr. Patta, thank you so much for your comments. Patta sir, I think we can close this session and maybe meet for
another wonderful session. We shall meet next Friday. Thanks, everyone. Thank you.
Thank you, Dr.
Thank you.
Thank you all. See you. Good night.
Thanks.
Thank you, guys. Bye-bye.